Well, welcome everyone. I can't wait till we can be in person because it's way more interesting and fun and interactive. So we're going to just try to get through some new information today, actually, about how we're going to classify, localize, and then treat respiratory tract disease from top to bottom, basically. And in the process, of course, we're going to talk about PCR testing. Now, for those of you that have been to one or two of the other ones, the PCR segment will be a rerun. I don't think it ever hurts to review, but we got to go through it because that's kind of just the important thing about how PCR can add to our ability to accurately diagnose infectious causes of respiratory disease in both dogs and cats. And then I'm going to show you some data on prevalence of various infectious organisms causing respiratory tract disease in North America, just to show, here's what the textbooks say we see most commonly, right? But now we have actual big data, like tens of thousands of PCR respiratory panels run that we can actually determine, well, do we need to rethink that? So it's a very useful tool, I think, to give the profession an idea of whether it's time to rethink our previous notions on prevalence with emerging infectious diseases. Are we going to detect anything new? And this will just help veterinarians address the most important organisms in their patients, which also, by the way, where does the data come from? People sending in samples for PCR testing. So it's kind of this virtuous cycle, right? The more information that we get, the more information we have to help veterinarians, which is the whole point. So we're going to use this document as our guideline. So I always talk about ACVIM consensus statements and other guidelines. And when it comes to respiratory tract disease, this is the must read. Okay, so this was a document published a few years ago now, about when do we use antibiotics to treat respiratory tract disease in dogs and cats. But in this document, which I highly recommend, it's open source, as you can see, they're open access, you just get it. All of what I'm going to talk about is basically a summary of what's in this document, and including drug dosages. I'm going to, at the end of the presentation, I have two slides, excuse me, of a sort of a mashup of the most common drugs recommended and their dosages, but it's all from a table in this document. So let's get rolling. So I think what we understand is that upper respiratory tract diseases are really common in both dogs and cats, usually younger dogs and cats, and more common in cats, I think, right? So let's just update the terminology and kind of review the common pathogens and the way to work through these cases. So the current term for upper respiratory tract disease in cats is feline upper respiratory tract disease, so that's not that much of a change. You should reserve the use of the term, or we should reserve the use of the term upper respiratory infection, or URI, for when there is a documented infection, an organism there causing the signs. All right, because there are other things besides infectious causes of upper respiratory signs, which we'll talk about. Dogs, the terminology has changed. So now, instead of tracheobronchitis or infectious canine tracheobronchitis or kennel cough, the appropriate term for that whole thing is canine infectious respiratory disease complex. All right, so clinical signs are similar in both, right? Coughing is more of a thing in dogs because it is more of a bronchial thing, but sneezing, ocular nasal discharge, conjunctivitis can be seen in both dogs and cats. And usually these are relatively asymptomatic patients other than their upper respiratory signs, okay? Acute disease in cats is usually defined as 10 days or less, chronic greater than 10 days. In cats, this is mostly a viral problem, herpes and caleci, and though there are instances where there are secondary bacterial infections, and now we know that there are also a raft of bacteria in cats that can cause primary upper respiratory tract infections. This is really where the PCR can come in handy, okay? And then in dogs, it's more of a cough situation, than sneezing, but sneezing can occur, same ocular nasal discharge can occur. And in most of these guys, dogs and cats, it's viral, and the ocular nasal discharge is serous, okay? It can become mucopurulent. We'll talk about how significant that is or isn't as we go along. And then you can see the common causes of viral and bacterial canine infectious respiratory disease complex on the right-hand side there. And a key factor is that co-infections are common, and this is similar to what we see with vector-borne disease. So this is where our PCR panels that include multiple pathogens can identify all of their offending organisms. A couple of things to point out in cats. So calicivirus is usually more severe, maybe more oral ulcerations, right, than herpes. So herpes latent can reactivate with stress, maybe more conjunctivitis. Okay, so there are some ways by looking at the cat you might be able to identify which is which. In dogs, even if there are no other signs of distemper, so no GI signs, no neurologic signs, any dog with canine infectious respiratory disease complex, these signs should be screened for distemper because of the health significance to the dog, and then any other dogs. And then if you have a severe hemorrhagic issue in a dog associated with respiratory signs or sudden death, this is something that we might make us think about Staph equi subspecies epidemicus. So the most severe would be that in dogs. And calicivirus can have that systemic form of calici and cause widespread disease as well. These things usually are confined to respiratory tract, but they can disseminate. Okay, that's sort of update on terminology and the overview of, I think, what we mostly know about how these infections go. And here are the species in cats that have been associated with primary bacterial upper respiratory tract disease. Some can also be secondary, but these are found in some cats with signs consistent with that disease complex that have no other organisms involved. And I don't think the list here is any big surprise. How do we manage cats with feline upper respiratory tract disease? Well, you just start by good history. Are they vaccinated against the offending pathogens? Have they been exposed to any other animals that might have had similar signs? And in cats in particular, they're cruising along doing great. Recent stress from hospitalization or surgery or another disease or immunosuppressive corticosteroids can reactivate herpes virus. So that would be the history. You might suspect herpes in fine, and then all of a sudden after some stressful event we have these upper respiratory tract signs. All should be screened for FELV, FIV, I think for obvious reasons. Immunocompromise might predispose to upper respiratory tract disease. And the deal here, and this will be a common thread, if the cat doesn't care in terms of no systemic signs of illness, we only monitor, no treatment, it's viral in most instances, and keep them away from other cats. Justifications for antibiotics in this disease in cats are when there are systemic signs. Okay, that doesn't mean that we just have mucopurulent nasal discharge. It's usually serous, but if it's mucopurulent, that per se, that change in character of the discharge doesn't mandate antibiotic therapy. It does if there are associated systemic signs, fever, lethargy, and inappetence. We don't want to do anything with the stuff that comes out of the nose, okay? Like the nasal discharge, we don't want to do cytology, we don't want to culture. Impossible to interpret the results because of the number of contaminants that could be in that sample. And if we decide to treat them, this will be another common theme, it's doxycycline, okay? And you can see the dose there. Now with cats, as you know, they're prone to esophagitis with certain medications. Doxy tops the list, also clindamycin. So in cats, on either of those medications given orally to avoid the esophagitis that can occur, we want to lubricate the tablet, literally coat it with butter. There was a controlled study done on esophageal transit time in cats that had pills coated with butter and pills that were not coated with butter, and the transit time was shorter, i.e. the pill got to the stomach faster, less time for erosive gastritis to occur. So it's butter the pill. It also causes the cats to lick their gums, and that causes salivation, which helps the pill get to the stomach quickly. Or you can do the water chaser, as you know, warm water 6 cc's, minimum 2, and you could follow with a small meal. Okay, so just be careful with cats with oral doxycycline and clindamycin. We don't want to develop down the line esophageal problem. If they don't improve, or if the upper respiratory disease becomes chronic, i.e. greater than 2 days, it's time to rethink the diagnosis. Maybe it isn't just a straightforward viral or bacterial upper respiratory tract disease issue. There could be some other problem, a non-bacterial or viral organism, could be allergic, it could be neoplasia, especially if it's an older cat, inhaled foreign bodies, blade of grass, nasopharyngeal polyps, big concern in especially kittens with chronic or intermittent either upper respiratory signs or respiratory signs per se, like just difficult breathing, and those things hang out above the hard palate, so you got to get in there. Sometimes you'll see them either in the external ear canal if they originate in the eustachian tube. Well, they do originate in the eustachian tube, but most often we find them in the oral cavity, oral pharynx, but sometimes above the soft palate. So go up there with a flexible scope or dental mirror, gently retract the soft palate with a spay hook, under sedation, of course, and identify. Okay, so think about other things besides our straightforward infectious causes of upper respiratory tract disease with chronic URI in cats. Now here it's time to do more diagnostics, and we don't want to culture anything that comes out the nose, just spontaneously discharge. What we do in these patients, want to sedate them, or sorry, anesthetize them, and do that flushing of the nasal cavity from caudal to rostral. So again, flexible red rubber catheter goes up behind the soft palate pointing forward, and you flush that with sterile saline, and you get that stuff. And that's what you use for anything: cytology, culture, PCR, whatever you need. That's a valid sample. In some instances, scoping for biopsy could be helpful. And in these cats, again, dosages are to follow, but these cats might need additional antibiotic or longer antibiotic therapy, starting again with doxycycline if there's been a relapse and sort of a period of health between recurrence. Amoxi, we'll talk about what does and does not respond to amoxicillin in a minute, and then fluoroquinolones, if you're able to use them, can be effective against gram-negatives. That might be the culprit here. And if you're going to use a fluoroquinolone in a cat, you've got options, but if you have the option of pratofloxacin, it's my preferred fluoroquinolone in cats, least resistance to date, because it's the newest, at least that I'm aware of, and also minimal effects on the retina, so minimal side effects. For these chronic guys, we want to treat for 7, and if you're getting a response with your first antibiotic, go for a week past resolution of signs. If you culture and you get Pseudomonas in pure culture, then you really need to flush these guys aggressively, because Pseudomonas can cause these loculated, hard to get rid of accumulations of stuff. You got to get that out of there. And then these guys, need mostly really good coverage for its gram-negative, so potent gram-negative antibiotics like fluoroquinolone, sometimes combined with penicillin that's augmented with either a clavulanic acid usually. Okay, if this is a recurrent issue, so there's health in between, no signs in between, and then another relapse, use the last effective drug for these recurrences and continue to search for an underlying cause. And this might actually end up involving skull imaging, either radiographs or CT for hard to find lesions in any other way. And then if you don't get a response to the last drug you use after 2 days, it's time to switch to another class of drugs. And here is what is on the respiratory disease PCR panel for cats at IDEXX. So the most common organisms are certainly tested for, and some other ones like influenza virus. Okay, so here's what is run when we have the need to run PCR in upper respiratory tract disease in cats, and that's usually with chronic, unresponsive, or recurrent disease. And you can see here that feline herpes virus type 1 is quantitative, and we'll talk about that as we go along and how that can be helpful in determining whether your positive herpes PCR is just latent, hanging out there, or potentially causing clinical signs. Quantitating that amount of herpes virus DNA can help determine whether it's the cause of current signs, address it, or it's hanging out in the background, keep looking for some other cause. Do you put anything in the nose of these guys? Well, you don't put any medication or antiseptics in the nose. No antibiotics, no antiseptics in the nose. But, to help clear secretions, then topical saline can be used, a drop or 2 in each nostril, 2 to 4 times a day, can be a mucolytic and help clear secretions. Also, a really helpful way to make these cats feel better is to do some humidifying nebulization, again, all with the point of moisturizing and loosening dried secretions so that they can be removed more easily by sneezing or by us gently dabbing away at the external nares so that these cats can smell so that they can eat. And this is also the same for the eyes. It's all about nursing care. And you guys, as I'm sure you know, you have the magic nurses in your clinic or technicians in your clinic that are really good in the isolation ward at getting these cats to eat by just babying them. All of that's really important. And then other tricks to make them eat is to make the food smell better by warming it or adding kind of juice, tuna, clam, whatever, and also maybe a little bit of powdered garlic, not too much because we don't want to cause sort of oxidative damage to the red cells. Okay, nursing care. And then again, most of these guys, even when they're severe, they tend to resolve on their own with just really good hydration, nutrition, and nursing care. Okay, So that's it for cats. Let's get on to dogs and their canine syndrome, infectious respiratory disease complex. And again, like with cats, usually viral, hence antibiotics aren't necessary. And even when it's bacterial, often it resolves spontaneously within 10 days, i.e. no treatment. So again, the nature of the nasal discharge alone doesn't determine the need for antibiotics. It's whether the discharge is mucopurulent versus serous and accompanied by systemic signs, lack of appetite, decreased activity, because that is an indication that we're beyond just confined to the upper respiratory tract. We've got systemic concerns here now. And again, like in cats, antibiotics only if those signs are present, and it's good old doxycycline again. It has the broadest spectrum against the bacterial causes of upper respiratory tract problems in both dogs and cats. You have other options for some of the pathogens, penicillins or augmented penicillins for Pasteurella, strep and staph, right? But important to remember that if you're using something other than doxy, you're not going to get any mycoplasma, and some Bordetella bronchoseptica strains are resistant to penicillins. So that's why doxy is the recommended choice. You can get away with others. If the patient won't tolerate doxy, it's not available. Just be aware that some of the common pathogens, bacterial causes of upper respiratory tract disease, are not responsive to penicillins, okay? And in the past, should we nebulize these guys with aminoglycosides? They're locally acting, it's gonna be great against gram-negatives, pretty broad spectrum in general. The answer is no, it doesn't work. Why? Because they don't work that great in infectious secretions or can't penetrate to the areas where they're needed because of the gunk in the nasal passages. If you got a dog that doesn't respond spontaneously, now these guys can come in. I'm sure it's hard to not give them antibiotics. When I was in practice and during my residency and training interns, it's really hard to not give a drug when you have a dog coming in with a pronounced cough, okay? Excuse me. So you got to stick to your guns. Usually not necessary. And again, when they are necessary, you will know because the dog will be sick. So just usually nothing besides, limited activity, maybe no neck leash, use a harness instead to minimize any tracheal irritation, that whole thing. If they're not getting better, then you kind of follow the same process that you did in cats. Is there some other non-infectious cause we should be looking at? So maybe scoping the nose for foreign body, looking up behind the soft palate for anything there. Maybe considering imaging if you've got any concerns. There's unilateral epistaxis, for example, or something that's making you think this is not the straightforward, canine infectious respiratory disease complex I'm used to seeing. And then if you're going to do anything on any secretion from the nose, it's got to be that sort of flushed from caudal to cranial procedure, and you really need gunk. Okay, so you're going to get a lot of fluid, and then you're going to get globs of mucus and other flocculent solid material. That's gold. Okay, so you want to be sure whether it's PCR, whether you're going to use cytology, submit for culture. You don't submit liquid. You have to have gunk in it for there to be a really good yield. And then this is the time then to consider PCR panel for other infectious causes or co-infections. And here's the list, and it's quite long. As you can see, covers pretty much all the culprits. And again, we got by the canine distemper virus PCR, we have quantitative, and this is again important because some young puppies that come in with these signs may be in their vaccine series, and you still want to know if they have distemper because of the health concern for that dog and others, as we mentioned earlier. And one way to determine whether your positive distemper PCR is due to vaccine, because the vaccine being modified live, like the herpes vaccine in cats, will be detected by the PCR test, but at a much lower level than an active or native infection. So being able to quantitate those two is really helpful in determining whether you've got distemper that's at a level consistent with vaccine only. So then we have to look for other causes of the upper respiratory signs. So that's it for upper airway disease. Excuse me, I got a little bit of a thing here. I just COVID tested myself this morning. It ain't that, thank goodness, but sorry for the sniffling, etc. Anyway, I have upper respiratory tract disease today, in fact. So anyway, let's move on down. We're out of the upper airways, we're down into the lower airway, and here we're talking about things above the alveoli. So between the mouth, the nasal cavity, nasopharynx, oropharynx, and the alveoli, lower airway. So this is trachea, and pretty much, and bronchi as well. So bronchitis, dogs and cats, no surprise here, coughing's the primary sign. If it's infectious in origin, it's usually the same pathogens as for the upper respiratory diseases in most species, but there are a lot of other causes of bronchitis in both species, from parasites to irritants to allergic conditions, think feline asthma, foreign bodies. Sometimes the cough is a bronchial cough induced by left atrial enlargement in dogs with advanced mitral valve disease, for example. So there are other things besides infectious causes. The primary offenders are the typical ones you would suspect, same as for the upper respiratory tract disease. And here, thoracic radiographs are a must. Now, thoracic radiographs do have a role in upper respiratory tract disease when it doesn't respond or resolve spontaneously. Just make sure there's not more broad pulmonary or respiratory tract involvement, lower as well as upper. But with bronchitis, absolutely radiographs. And the best way to identify or highlight the soft tissue structures, the cardiac silhouette, pulmonary vasculature, tissue, bronchi, etc., is on full inspiration. Not that critical. But if you can time that, that's great, because that's just more air, more volume of air to then contrast against the soft tissue and vascular structures. Here in dogs, because tracheal collapse is a common cause of cough and can be associated with or exacerbated by bronchitis, getting cervical and thoracic tracheal films on both phases of respiration will help you assess for dynamic collapse of the trachea, which involves the extrathoracic trachea on inspiration and the intrathoracic trachea on expiration. So try to get that. Sometimes fluoroscopy is necessary if you need to go that route, and then assess the heart as well. Additional diagnostics, other than looking at your minimum database for evidence of eosinophilia on your CBC, which could prompt you to think about parasitic disease, proteinuria on your urinalysis, which might make you think about any sort of chronic inflammatory disease like heartworm disease, and your chemical panel for is there protein, low protein component, which can be seen with some kidney and other diseases, etc. Looking at heartworm serology for sure, both in dogs and cats, coughing in cats, asthma, or heartworm disease. So if you have a coughing cat, make sure you screen for heartworm disease, and that in cats is a little trickier than dogs because the antigen test isn't that sensitive, because cats often have just one, maybe up to 3 worms, not enough for that test to be positive. So in cats, if you get a positive antigen test for heartworm, you've got the diagnosis. If you have a coughing cat and your antigen test is negative, then you would do a heartworm antibody test, all right? And that, if it's positive, would tell you heartworm's going to happen. If the cat's been exposed, the larval forms are working their way to the heart, or the cat has heartworm, or it had heartworm. So at least you know that heartworm's in the mix, and it's time to maybe get an echocardiogram, at least get the cat on preventive, that sort of thing. So in cats for heartworm, the feline heartworm panel, including both antibody and antigen testing, can be super helpful. Okay, how do we treat it? We're back to doxycycline. Why? Broadest spectrum. All right. And again, the duration of treatment for both upper respiratory tract disease and bronchitis is 1 week beyond resolution of signs. We'll talk about new information on how we can tailor treatment for pneumonia and why we can't use that for bronchitis in a little while. And again, these guys, if it's chronic or recurrent, it's time to get in there and do either some kind of airway procedure. All right, for obtaining samples for cytology, maybe mucosal brushing, more sensitive and specific than just flushing and recovery, samples for culture and susceptibility testing, PCR testing. And here, if you can, bronchoscopy is the way to go, because you can do a thorough evaluation of both, all the main stem bronchi, trachea, etc. Get your samples. Bronchoalveolar lavage and brush specimens are the most accurate ways to recover either infectious causes or identify non-infectious causes of neoplasia and others, right? If that's not an option, that's fine. Your typical transtracheal wash right through the endotracheal, sterile endotracheal tube, perfectly fine. The keys there, you have to make sure that your sterile catheter into which you're injecting the saline is beyond the tip of the endotracheal tube. You don't want to aspirate fluid in the endotracheal tube, so you have to make sure that that tip of the catheter that you're infusing the fluid through, saline through, is beyond the tip of the endotracheal tube, and then you really need to provide a lot of negative pressure. So vigorously aspirate or suck on that, pull back on the plunger of that syringe, and you won't get much stuff. You might, for a cat, 5 to 10 mLs, for a dog, 10 to 20 mLs. You might get 1 to 2 back. It just diffuses throughout the lung, right? It's a huge surface area there. So that's fine as long as there's flocculent debris, mucus, solid material in that sample, because that's what you need. If you get clear fluid only on your transtracheal wash, I would do it again. Just repeat the procedure and really aspirate until you can get, if you're lucky, you'll get that tip of the red rubber catheter, which is kind of most commonly used, maybe against the wall of the bronchi, and then by sucking, you might even get some cells out of there, and where bacteria can adhere to, and that may be recovered more easily there. So you get the picture. All right, and then same, PCR testing, make sure it's on flocculent material. Okay. Going further into the lungs, so bronchopneumonia or bacterial pneumonia in dogs and cats, it's almost always secondary to something else. Primary bacterial pneumonia does occur, but whenever I have pneumonia in my patient, I'm thinking, do we have aspiration here? Is there some foreign body that I'm not seeing? Is there something wrong with this dog's overall immune system that's predisposing, or an anatomical issue in the bronchi themselves, or trachea, bronchiectasis, collapsing trachea, ciliary dyskinesia in, say, pugs and other breeds. Those are the things that we want to just keep up sort of a wide differential, cast a wide differential diagnosis net. Okay, we just don't want to assume pneumonia, bacterial, antibiotics, we're good to go. That might work, but there may be some underlying disease, and if we find that sooner, then we prevent recurrences and we have more effective response to treatment. No surprise on what this disease looks like, and you can use the pattern of pulmonary infiltrates to help you assess the likely cause, if it's infectious, of pneumonia. So when we think about bronchopneumonia, we think cranial, ventral. When we think viral pneumonia, it's more diffuse and interstitial. Aspiration pneumonia, maybe more right middle lung lobe. So the distribution can help kind of get you in the mix or narrow your differential list, but the workup's the same for all of them. And then treatment, ideally based on cultural susceptibility of pulmonary secretions, if your patient's stable enough to allow you to get those, which we usually require at the minimum sedation, if not anesthesia, which it's usually anesthesia, okay? If you have to provide symptomatic treatment because your patient's unstable or finances limit what you can do, then the options are the same as for every other part of the respiratory tract, which makes it pretty simple. But however, when these guys come in and they're febrile or their neutrophil counts are really low, indicating acute suppurative infection, and they're in distress, and you know, the ones that don't look great, the sooner we can get them on potent, broad-spectrum injectable antibiotics, usually in combination, so maybe a fluoroquinolone or aminoglycoside for gram-negatives with a potentiated penicillin or clindamycin or metronidazole for, you know, anaerobic or more broad-spectrum gram-positive coverage, helpful. Also, these guys need to get that stuff, those infectious secretions, out of their lungs, okay? So we want them moving to help the ciliary mechanism, mucociliary apparatus work. We want to perform coupage, so cupped hands, both sides of the chest, vigorously cupped to sort of break up and loosen secretions, keep them hydrated. So this is no time to be skimping on intravenous fluids. You have to be careful, because if there's increased permeability, vascular permeability from inflammation or infection in the lungs, possibility that your crystalloid fluids that you administer will increase lung water, could potentially worsen respiratory signs. So just monitor carefully, but it's way worse to withhold fluids, because that just keeps those infectious secretions in the lungs. And with any infection, drainage is the key, right? And how do we get fluids out of the lungs? We don't really drain the lungs. We just help the mucociliary apparatus work better by hydration, get them up and moving, and coupage. If they're ventilated or really sick, so they can't walk, then it's all about rotating various positions. Keep them probably off their backs, so maybe not, you know, dorsal recumbency, but flip them around. So a few hours on left, sternal right, and sometimes there'll be a position that just doesn't work. And so when you change their position, you have to keep a very close eye on them for the first, say, 20 to 30 minutes, because they might desaturate and become severely hypoxemic. So if there is, like, this dog does great here, leave that dog there. Do the coupage, keep them hydrated, right? if they can be moved, rotated, that's great for helping those secretions. Okay, now here's what's kind of new. You know that radiographic signs lag behind clinical signs, both initially, so they'll come in looking like the respiratory signs are more severe than the radiographs show. The radiographs will catch up, okay? Same on the back end. As they recover, they look better before the radiographs improve. So radiographs have traditionally been our method to monitor response, and it's useful. Serial radiographs are helpful. Are you seeing some improvement? Is there something else happening? Now do we have pleural fluid? Because pylothorax, by the way, one of the most common causes of pylothorax is extension from pneumonia. We used to think pylothorax happened from external thoracic injuries, penetrating injuries mostly or only, but that's not so true. A lot of the times it's extension from pulmonary infections, or if you've got a gas former or pulmonary leakage from a corrosive organism, you might have pneumothorax, right? So you definitely want to take serial radiographs. But now look at your serial CBCs daily if they're really sick. Look at those graphics, because the numbers on the CBC might not, the total number of white blood cells and neutrophils might not change and might be normal as the differential varies. Maybe there's a neutropenia acutely and a high band count, so that's a normal count. As they improve, maybe the band count goes down and the neutrophils comes up. The differential has changed, but the total might not have changed. So look at your graphics, your dot plots, if you're using, you know, what do you call it? The ProCyte DX, and those dot plots are very sensitive because they'll tell you what each cell population among the white cell differential is looking like, and if the dot plot's returning to normal, even though the numbers might not be changing, that's a good sign. But also C-reactive protein, and we'll talk about that in a minute. So what is C-reactive protein? Sure, you guys are way more on top of it than we are in the States, because to learn about in vet school, it is not taught in vet school. We don't know anything about it. It's available now in-house and in the clinic, and so we're getting a lot of information around the benefit of it, as I'm sure you guys already know, or I'm pretty sure you do. Most other areas of the world, you're way ahead of us when it comes to the benefit of following systemic inflammation, diagnosing it and following it in dogs using CRP. Okay, how long do we treat bacterial pneumonia? This is where CRP comes in. So long-term therapy has been the standard, basically until we saw radiographic improvement, because that was the objective measurement we had to assess response. In humans, though, not nearly that long. Excuse me, not nearly that long of a duration of therapy, and probably because they're better at getting cultures sooner and really using targeted antibiotic therapy, where often we can't get the samples we want to have, so we use empiric therapy, which may not be effective, the whole thing. But there have been a couple of papers published in the Journal of Veterinary Internal Medicine in the past few years that have addressed, can CRP, this marker of systemic inflammation in dogs, not cats. Cats have their other positive acute phase proteins like serum amyloid A. Dogs too, but dogs CRP. And the beauty of it is 6 hours after the onset of systemic inflammation from any cause, it will increase. And then having a short half-life, it returns to normal quickly if your treatment is effective. Used in people to both diagnose it, because if we're looking for an infectious cause of pneumonia, we'll expect to see a CRP higher than a non-infectious cause, and that's been shown in people as well as in dogs. Dogs that come in with signs of respiratory distress in the lower airways that have the higher CRP values have bacterial pneumonia versus, say, aspiration pneumonia or other types of lower airway inflammation. So now, what are we going to do? Well, nothing to be really definitive about yet. It has been shown in both of these studies that CRP normalizes before radiographs do. It's a much more nimble marker of resolution. And it's also been shown that treating until the CRP is normal and then stopping, even if the radiographs aren't normal, there's no difference in outcome between that shorter duration of therapy till CRP normalizes or until radiographs normalize. So I think, as has been the case with treating urinary tract infections in dogs and cats, where the previous recommendation was to do longer durations of therapy, and now we know they're not necessary for bacterial UTIs, I have a feeling that another consensus statement, or as soon as more information becomes available, the recommendation will be similar in dogs with pneumonia. Maybe cats, when we get the ability to do a good marker for systemic inflammation in cats, like an assay for serum amyloid A or others, although pneumonia is more common in dogs than cats. So you get the picture. The point here is you have a new tool to monitor your dogs with pneumonia. Are they responding? Sometimes they're on the ventilator, so you can't look at appetite, mentation, activity, none of that. Sometimes they're just laying around and sort of they're sedated a little to keep them comfortable, or they're just not clinically giving you any clues or strong clues. Radiographs take days or longer to improve. So this is a really important, useful, nimble tool. Is your treatment working? If the C-reactive protein on a daily basis, at least initially, until you can determine the trend is going down, you're on the right track. If it does not, then if you haven't gotten your airway procedure done for samples to culture PCR, do it. Or if that's been done, and you've chosen the initial course of antibiotics and we're still not getting anywhere, think maybe I should get a CT scan on this dog if that's available. Is there a pulmonary abscess? Is there something that I can't see radiographically? And then maybe scale up antibiotic coverage. Okay, so we've talked about PCR in terms of when we use it for respiratory tract disease, not initially. Whenever it's time, whether it's an upper respiratory problem or lower, whenever it's time to get samples because our patient's not responding, or initially in pneumonia, from the airways, whether it's a nasal flush for upper respiratory tract disease, or whether it's an airway procedure, transtracheal wash, bronchoalveolar lavage, for lower airway disease, that's when we get our PCRs run. Detecting DNA of the organism, again, compared to serology, way more sensitive and specific, and allows earlier detection because you don't need to wait for that lag period before antibodies are produced for detecting infections, that sort of seroconversion, which on average is about 2 weeks for most pathogens. So advantages galore. And the way it's run, the PCR today is nothing like the initial PCRs. It's in a closed system, minimal contamination, which is why it's so specific. And then there's a amplification phase where the initial sample is duplicated 45 times through 45 cycles, ending up with trillions of copies of DNA, which makes it really sensitive, really helpful. And it can also be quantified. The amount of DNA, or in some pathogens, RNA, can be quantified, and that can be helpful when, I'll get back to those slides I just went over just to continue my train of thought. The quantitation can be helpful when it's important for us to determine whether we just found an organism there that's normal flora or that's not causing any signs, or whether this is an organism that is in significant or high enough number that we need to treat it. So clinically it helps us make treatment decisions, and we can also use it for cats with FELV, with combination of the SNAP FELV test and quantitative FELV PCR. Now we can stage those cats better. Are they a regressive cat, not infectious, not likely to be ill, or a progressively infected cat, sick, contagious to other cats? The difference there is how much DNA there is. So there's a cutoff above which we've got progression, treat that cat like a positive infectious cat, below which we have regression, watch the cat. And then knowing that the cat's immune systems can change because of age or other disease or drugs, corticosteroids, the cat can switch between progressive and regressive. And now we have a way to identify that and help our clients, right? And also, as we mentioned, in dogs or cats that have been given modified live vaccines, those vaccines are picked up by PCR testing, so being able to quantify the amount helps us determine if it's vaccine, lower level, or actual infection, higher level. So with PCR testing, backing up a little bit, sorry for the flipping around, it's the most sensitive and specific test we have for infectious disease, okay? And the way we interpret it is, if the organism is there, PCR is going to find it. If the organism is in the sample, when you get the sample, the PCR test is going to find it. Then it's up to us as clinicians to determine what that means. Again, going back to, is it normal flora? Is it in low numbers? Do I have to keep looking, or do I direct my therapy toward this pathogen? Because PCR is so sensitive, a negative result, you don't have the disease most often. However, what could also cause a negative in a dog or cat that has the organism you're after? Well, if the organism is hiding somewhere other than in the sample you got it. So let's say you do an airway procedure and you just don't have flocculent material or debris, and you submit it anyway. a negative result on that is not convincing to me, right? Or let's say you have leishmania and it's chronic and the organism is in the spleen or the bone marrow. You're not going to get it in the blood, okay? So the caveat to a negative meaning negative is you have to make sure that the bug is in the sample when you get it. A good enough sample and biology of the organism should help us decide where to get it. You can go after leishmania or Ehrlichia in the bone marrow or the spleen. It doesn't have to be done on blood PCR, but it usually is for those kinds of organisms, like those vector-borne diseases. Also, there can be a strain mutation of a virus, a new mutation that has a different genome than the strain that the PCR is directed toward. When that happens, eventually we figure it out and we get a new PCR for more strains. And this is something that's happening with FIP PCR, the most sort of common mutation for North American and European strains of FIP virus is a spike gene mutation, but there are other mutations that can cause that benign enteric FIP benign enteric coronavirus to mutate into the pathogenic horrible FIP coronavirus. There are other mutations that can do that, and as they become more common, we'll be able to figure it out and then do a broader array of FIP strains to have fewer false negatives. Okay. We talked about the quantitative results, and here's kind of a list of what quantitative PCRs are available. We talked about the distemper, we talked about the herpes and the FELV PCR, leishmania as well. Is it sort of subclinical or just sort of a chronic patient, or one that has a higher amount of leishmania that would warrant therapy? We know now that with the previously known condition in dogs, that hemorrhagic gastroenteritis, that is now called acute hemorrhagic diarrhea syndrome. The Clostridium perfringens produces a toxin that's likely to be the cause of that, and the genes for that toxin, the NET-E and the NET-F genes, are now available to be detected and quantified, because Clostridium perfringens lives in everybody, right? And these genes might be found in low levels in normal animals, but if you find a high level of either of these genes in a dog, for example, that has those signs of acute hemorrhagic diarrhea, is it parvo? Is it AHDS? Okay, not HGE. Excuse me. Do this test. This test is not positive in parvo dogs, right? So anyway, quantifying, super helpful. Okay, so just to kind of wrap up here, let's look at just reviewing when we're going to consider PCR testing in the workup of a dog or cat with respiratory tract signs. And usually, especially from a referral veterinarian standpoint, these are animals that have been kind of worked up well or treated symptomatically and have had recurrent problems, and they're not getting anywhere. So now it's time to anesthetize them to do advanced imaging and scoping. This is when we want to be thinking about inserting PCR in there beforehand, because we want to be sure to have eliminated infectious causes or multiple co-infections, and perhaps there has been appropriate therapy for a bacterial cause, and now we have a viral cause, right? So PCR gets inserted after failure to respond to sort of normal therapy or lack of resolution in an upper respiratory tract disease, when it's time to do more diagnostics, and any time in a lower or upper airway disease, before we do anything more invasive that requires anesthesia, we want to get that PCR done. Now, here's what's helpful. Like, how do you do it? How do you interpret it? If anybody has VetConnect Plus, it's all there. This is basically, I just copy this out of VetConnect Plus. It's all there. And the key here, I'm not sure you can see my pointer. When we do upper respiratory tract PCRs on dogs and cats, we do both deep pharyngeal swab, look, visible organic material, please rub firmly, that's so important, and a conjunctival swab with a cleanly wiped eye on the inside of the eyelid. Okay, so 2 samples, same tube. And then we have interpretive comments here. So it's all there, basically. So if you have in a dog a positive distemper, you're going to automatically get quantification, so you can determine if it's real infection or vaccine. If you get a positive influenza, identify the strain. All right, so it's all here for you. Similarly in cats, the same test protocol, the same sample acquisition. It's both deep pharyngeal swab with gunk on the swab and a conjunctival swab as well. And then if we have a positive PCR in the cat, I'm sorry, a positive herpes virus PCR in a cat, then that will be quantitated. Okay, so it's all there, super helpful, makes it pretty clear. Now, just to kind of show you how it goes, in order to get like the cleanest, in order to minimize contamination from the oral cavity with the millions of organisms that are just hanging out there as normal flora, you really want to direct that sterile swab into the caudal pharynx, okay, into the pharynx. And to do that, it helps if you can get the cat to be amenable to pass it through a sterile syringe case, okay? If you can do it, like, be careful, like, let's not put ourselves or our staff at risk there. But that's one way to minimize contamination from the oral cavity, because these panels test for a lot of organisms. Some are normal flora, and what matters when you identify them is the amount, if that's possible, by quantitating the PCR test or the clinical signs associated with your patient. Again, a positive PCR means the thing is there, up to us to put on our doctor pants and decide if that thing is really the cause of my patient's signs. And in dogs, just use a bigger syringe case, same mechanism. Okay, just try to get as clean and as uncontaminated sample as you can by directing that swab through a sterile syringe case. One last thing, you can use PCR just to monitor response. So, did your treatment work? Is there some persistent unresponsive organism that might make us think maybe we do have a mass in there, maybe we do have an abscess now, something else to pursue? All right, so one and done, not necessary. Most often we just use PCR to diagnose respiratory pathogens, but it can in certain instances, and these would be the referral cases or the really chronic ones where you're thinking there may be multiple problems, you want to eliminate one. Yes, we've cleared the infectious cause, so now we have to address other causes of these persistent signs. You kind of get the picture there. So I just wanted to show you what happens when people send in PCRs. We got big data now, right? We have over 60,000 samples in dogs in 1 year, and in cats we can compare two years, the year between 2019 and 2020, where there was 1,673 samples, to 21 and 22, where there's over 70,000. Now, why would there be so many in that year? Because everyone was concerned that COVID, SARS-CoV-2, was causing disease in dogs and cats, right? So there were so many PCR respiratory panels done because there are my friends who are still in practice were like, are you seeing it in dogs and cats? Because I'm seeing way more animals come in with respiratory signs, right? So everyone was concerned. So that's the jump in the number in cats between those two sequential years. And you can see that the list of common causes is pretty what you would expect. Although, you know, we're told that in cats, feline upper respiratory tract disease is mostly viral, feline herpes and calici. Well, look what we got most often. Mycoplasma felis. Is this normal flora? Were these cats not really clinical for mycoplasma? Who knows? But look at the list there, right? And we think that in dogs, same thing. It's their canine infectious respiratory disease complex, usually viral. Is it? The two most common are bacteria, right? So this allows us to sort of really think about, are these mycoplasma really significant? Are they the ones we should be thinking about? Well, doxycycline for sure. That's why it's recommended for any initial treatment for respiratory tract disease, regardless of whether it's upper or lower, because look, there's a lot of mycoplasma. So, and it's not responsive to amoxicillin, right? So it helps us epidemiologically and also justifies our choice of therapy, okay? So when we get more information, then we can share it and we can tweak the recommendations if that's indicated. So all of my veterinary friends in practice who were convinced they were seeing COVID in their dogs and cats, were they? No. Very, very few positives. And then who knows what those mean, right? But again, it can really help us determine whether we do have, if this had been a higher positivity rate, then that would be a whole nother wrinkle in the pandemic situation. Could they be a reservoir for humans? Are they getting it from humans, right? Or, so anyway, super helpful. And another thing about PCR testing is it's really nimble. So it didn't take long at all for IDEXX to come up with a PCR test for this virus, which could be used in dogs and cats. So just another benefit of PCR and having the right kind of equipment, this real-time PCR that allows really rapid development of really accurate assays. So I think we've already talked about all of this stuff. I don't need to repeat it to you guys. You can take a look at that. And I just wanted to, now I don't know how I should do this. I'm going to just, I'll show you. There are 2 slides left, and they have the choices and the dosage of antibiotics based on where your respiratory tract infection is. I'm going to leave it on the antibiotics and the dosages, the most commonly recommended one from that guidance. But remember, don't panic. It's all, I just literally cut and pasted these slides from that consensus statement. Okay, we're done. We got done in time. I'm happy about that, and I'll be happy to answer any questions. And again, thank you so much for spending your evening with us. Can't wait to do it in person. And for those of you that have been to 1 or 2 of the others, that's really great. Appreciate that. And anybody who wants a PDF of the talk, just let the organizers know somehow, and they will get that to you. So thanks so much.
Seja bem-vindo à sua nova conexão com os seus diagnósticos laboratoriais. VetConnect é o novo portal digital do Laboratório de Referência da IDEXX. Uma plataforma completa de serviços e informações sobre seus diagnósticos, que pode ser acessada onde e quando você quiser. VetConnect é uma ferramenta prática, rápida e muito fácil de ser integrada em sua rotina clínica para solicitar testes eletronicamente, ao invés de requisições em papel, economizando tempo e evitando erros. Acessar o histórico detalhado de seus pacientes. Agendar a retirada das amostras. Quando suas amostras chegam no Laboratório de Referência IDEXX, você pode acompanhar o processamento dos seus pedidos em tempo real. Após a conclusão, você receberá o laudo de resultados por e-mail. Ele também ficará sempre à disposição para ser baixado no próprio portal. E para facilitar ainda mais a sua rotina, o IDEXX VetConnect possui o recurso de compartilhamento para que você possa enviar uma cópia do laudo para o tutor. Além de todos os benefícios para a sua rotina clínica, o portal IDEXX VetConnect oferece ferramentas analíticas que ampliam sua visão sobre a saúde do paciente. Recursos como gráficos de tendências permitem a comparação interativa entre os diversos resultados de seus pacientes ao longo do tempo. Com a IDEXX, você está sempre conectado ao futuro das informações diagnósticas. Vem agora para o IDEXX VetConnect e descubra mais!